Perfect. Okay. Well, hello everyone, and welcome to our third iteration of the UCGHI Grand Rounds webinar. My name is Maxwell Mattern, and I am the program analyst at the UC Global Health Institute, also referred to as UCGHI. I work on the education side of the institute, supporting out UC online classes focused on global health, and I support the UCGHI Student Ambassador Program as well. In case you are new to the community, UCGHI is housed within the Office of the President, and we bring together faculty, students, staff, and community partners across all 10 of the UC campuses. And we work to advance health equity through research, education, and partnerships so our people and planet can thrive. Please drop your name and institution or organization you're attending or work at so we can know who is in this space today. So please put that in the chat. Um, Today's topic is nutrition and food security. And the session will bring together diverse perspectives on the structural, social, and health dimensions of food access, from local policy to global research and clinical practice. Together, they'll explore innovative strategies to address food insecurity, advance equitable food systems, and improve health outcomes across communities in California and around the world. It's my pleasure to introduce our three speakers, Dr. Carrie Waterman, Dr. Isabel Madzorera, and Dr. Sheri Weiser. Dr. Carrie Waterman is an interdisciplinary research scientist at the intersection of nutrition, agriculture, and health development. She received her PhD in pharmacognosy and spent the following years as a postdoc in natural products chemistry. Dr. Waterman was a Fulbright scholar at the University of Nairobi, Kenya, and served as a Peace Corps volunteer in West Africa. She later worked as a professional research assistant in nutrition at UC Davis with the NIH Fogarty International K01 grant. Dr. Isabel Madzorera is an assistant professor in food nutrition and population health. Her research is in global nutrition, and she conducts multifaceted research that assists in understanding the determinants of poor maternal and child nutrition outcomes in low and middle income country settings. Her research aims to address the global health problem of poor quality diets among women, children, and adolescents, and its relationship to the triple burden of malnutrition in low and middle income country settings. Specifically, her work focuses on elucidating the intersection of diet, nutritional status, food systems, and maternal and child health. And our last speaker, Dr. Sheri Weiser, is a professor of medicine and internist at UC San Francisco's Division of HIV, Infectious Diseases, and Global Medicine at Zuckerberg San Francisco General Hospital. Her research focuses on the impact of food insecurity and other social and structural factors on treatment outcomes for HIV and other chronic diseases. Dr. Weiser also evaluates food insecurity interventions as a way to improve health outcomes in domestic and international settings. She's published over 100 manuscripts on food insecurity and related topics, including HIV stigma, mental health, and women's empowerment, and has been the principal investigator on over 20 grants in the area. She completed her medical degree at Harvard Medical School and then completed residency training in internal medicine at UCSF. For today's webinar, each of our three speakers will have about 8 to 10 minutes to present. There'll be time reserved at the end of today's webinar for Q&A discussion. So if you have any questions throughout the presentation, feel free to submit them in the Q&A box or in the chat, and we'll address them at the end of the presentation. So with that, please join me in welcoming our first speaker, Dr. Carrie Waterman.
Thank you, Maxwell. I really appreciate the introduction and the opportunity to be on this panel with so many other amazing folks as well. As you mentioned, I was a Peace Corps volunteer in West Africa and really was fascinated with kind of plants and livelihoods from a pretty young age. Spent time in India as well, so really was around large populations that were living at or below the poverty line. And was also really interested in plants, got a degree in natural product chemistry, and did a lot of research on the moringa plant, which is really grown and used throughout the tropical, subtropical region around the world. It's native to India and Pakistan, but now grows in Africa, South America, Central America, and even here in California. So with that degree, I was kind of back and forth on both continents and always really interested in this idea of diplomacy and especially getting young students involved in having a global perspective of what's going on. I was fortunate to participate in the UC One Health RX program, which took place in Tanzania and Kenya, where we were looking at environmental, human health, and animal health interactions. And they had students from UC Davis and Tanzania and Kenya coming together to solve really challenging problems that involve the gorillas coming out of the park, and conservation efforts, tourism, government interest, and the students were able to kind of compile an idea of a solution and present that to the ministries. And these are the types of examples that I've really been really honored to be a part of. Basically, a lot of peer-to-peer learning, cross-continental, cross-community learning through the Fogarty Grant. In Kenya, brought farmers together from different regions, which even though it was only a couple hours away, felt to them like a very intercultural experience where the food was different and the language was different, but the farming and the basic needs of life were the same. Currently, California and Kenya has an MOU to address issues of transportation and food access. And so these are really interesting opportunities, I think, for faculty members, community members to get involved in these really global problems that, you know, affect both residents in African, sub-Saharan Africa, as well as the Central Valley in California. Through these experiences and kind of getting to know moringa farmers and moringa researchers in Africa and going to conferences in South Africa and Brazil and connecting with folks in the South and Louisiana, when the UC Global Health Institute offered the opportunity for a pilot center, we applied. This was during COVID, so it was $10,000. And what we suggested was to have an online forum to bring folks together that were addressing food access and also Black Lives Matter issues. And so looking at some of the historical context of food access within the US, but we were able to host a variety of speakers, and that was really useful for folks to kind of speak on different topics. We had 25 hours of content, over 500 different guests. And in the second year, as the COVID restrictions kind of lifted, we were able to also do in-person events in Sacramento, California with the Capitol, at the Capitol, and in San Diego at the World Beat Center. Sheri, who's on this panel, was also a guest who really provided amazing insight. And so this was really a platform to bring university researchers together with nonprofit organizations that were kind of on the ground trying to address problems, and then trying to tie them to sources of funding, either through university mechanisms, state mechanisms, or federal mechanisms. Unfortunately, after 2 years of funding, we weren't able to secure it further than that, but the videos are all online and accessible on YouTube, and it's still a scaffold that can be built on. And so while I'm no longer at UC Davis permanently, I still part-time teach there. I'm involved with a business school. I'm also helping to advance this MOU between Kenya and California forward. So all of these connections like really build on each other. And I think it's really great that even though I'm not at UC Davis, I can still be affiliated and participate in these types of activities. Through the state, I currently work for the Department of Food and Agriculture in the Office of Farm to Fork, and we support the Nutrition Incentive Program, which is about a $40 million annual program to provide CalFresh or nutrition benefit recipients that have EBT benefits at farmers markets. So to double their dollars there on purchases of California grown fruits and vegetables. So it's a very different perspective where I was working on one plant and trying to bring kind of communities together to looking at this global food access, or sorry, statewide access across California, looking at very dense urban areas like Los Angeles, and also rural areas like Northern California, Lassen, and Modoc. So the experiences are still relevant. I still think that peer-to-peer learning is really the biggest asset. And, when entering into communities or working with folks that you might have kind of a broader, bigger perspective, that really, working with locals and building on that trust that's already there can be such an asset. And I think more forums like this to get ideas to see what people are doing in different places and how they're able to kind of work across, community boundaries, state boundaries, and local connections is really phenomenal. I can share the YouTube video that just introduces kind of the Center on Food Justice in the chat, and I'm happy to take any questions as well. And I'll just add, we are, currently looking for funding to keep this center and this platform going. We just really want to be able to offer speakers that come on a cash incentive, basically, and kind of paying for their time, and really recognizing that community organizations and leaders can have, despite not having a PhD next to their name, can still have as much really clout in the community, informational knowledge, institutional knowledge, and so really trying to level those playing fields of kind of who gets the financial benefits of the grants as well.
Perfect. Thank you so much, Dr. Waterman. I really appreciate you kind of going in depth and sharing all those details. And definitely again the video is in the chat. So please, folks, please check that out to learn a little more and get a little more information about that. And we will, if you have any questions about what Dr. Waterman was speaking about, please feel free to put in the Q&A, put it in the chat, and we'll make sure to bring it up at the end. Thank you, Dr. Waterman. Up next, sorry about that. Up next, we have Dr. Madzorera. We will let her pop in and start sharing her screen.
Thank you very much. I am just, hopefully you can see me now. Excellent.
Yes.
Good. And let me see if I can change my screen to presenter mode. But I'm really excited to be speaking to all of you today. So I want to share a little bit some of my work and experience around global nutrition, which is really focusing on understanding how diets are an important risk factor for poor health outcomes, and really focusing on low and middle income countries, because these are countries where data and evidence linking these two still remains quite limited. So just to start us off, we know that in many low and middle income country regions, there are vulnerable women and children that usually do not have access to good quality diets. So with good quality diets, we're thinking about diets that are high in fruits and vegetables and can meet all the macronutrient and macronutrient requirements. Additionally, there are folks that cannot afford animal products. Here in the United States, we usually think about people over consuming animal products. However, in many low and middle income country settings, people actually cannot afford enough animal products, and so conditions such as anemia is really prevalent. At the same time, there's a phenomenon that's happening all around the world where there's a lot of transition in what people are currently eating. So we call this processed nutrition and dietary transition, where people are now consuming more processed foods, outer processed foods, refined foods, and so forth. And so the focus of my research is really trying to understand how food systems influence the quality of the diets that people consume, but also thinking about how the poor quality diets then also impact maternal and child nutritional outcomes. Now, if I were to move on to just to highlight some of the important questions that I've been working on the past few years, I could highlight maybe the role of pregnancy diets in the risk of poor birth outcomes. And I'll talk a little bit about what that means. Then, secondly, I want to also highlight the role of diet in non-communicable diseases. As I've indicated, non-communicable diseases are also increasing as dietary transition has been occurring in low and middle income country settings. So to start us off by thinking about maternal diets during pregnancy and poor birth outcomes. So there's some work that we've done in Tanzania, which tried to understand, for women that are pregnant, what role does their dietary intake during pregnancy have in the size of the infants that they give birth to. So in this particular study, we wanted to understand the role of maternal dietary diversity and diet quality in Tanzania. This study had actually recruited more than 8,000 women as part of a micronutrient a supplementation intervention. And the women were recruited in Dar es Salaam, which is the capital of Tanzania. Women's diets during pregnancy were assessed several times during pregnancy, and the study measured, birth weight at the end. It also measured, classified, births as a low birth weight, which is when, the birth size is less than 2.5 kilograms, or small for gestational age, which is when the infant is less than the 10th percentile of the weight for their gestational age, or if they were preterm, which is being born less than 37 weeks gestational age. And the study had really collected a lot of data on factors such as socioeconomic status, maternal education, paternal education, and so forth. And so we could really interrogate this question into great detail. Now, one of the critical challenges we faced was really, we wanted to understand the role of, pregnancy diets, but usually when we think about diets and diet quality in low and middle income country settings, people have often just thought about, how diverse is the diet? Does it have fruits and vegetables? We often don't think about consumption of unhealthy nutrients and unhealthy foods. So we settled on one metric that we thought could be tailored to the context. And this metric is called the Prime Diet Quality Score. The Prime Diet Quality Score assesses dietary intake and classifies diets into healthy components and unhealthy components. So for the healthy components, we have things such as different types of fruits and vegetables, lean meats, poultry, and so forth. And on the unhealthy side, it really penalizes or restricts consumption of unhealthy foods such as red meats, processed meats, and added sugar. So nutrients that we know are associated with really poor outcomes if they are consumed in excess. Now, the scoring for the Prime Diet Quality Score is that for the healthy foods, if a woman had consumed 4 or more servings in the previous week, she was given the maximum points. And if she'd only consumed 1 serving or none of the healthy nutrients, she didn't get any points. And then for the unhealthy foods, this is reversed, where the maximum points were given to consuming 1 serving or none in the previous week. And the PDQ score for a woman is just the sum score across all the different food groups that she consumed in 24 hours. Now, this metric, the PDQs, had been validated prior to our adoption of this metric. It had been validated for association with cardiovascular disease, as well as gestational diabetes and hypertension. In other words, women that consumed a good quality diet based on this metric were less likely to have cardiovascular disease or gestational diabetes or gestational hypertension. In our study, we then classified, so we took a woman's diet and created her PDQ score, and then we ranked women in terms of their PDQ scores. So the women that were in quintile 5 of the scores had the best quality diets, and women that are in quintile 1 had the poorest quality diets. And what we found when we compared women's diet quality to their birth outcomes, we found that women that were consuming the best quality diets had up to 45% lower risk of preterm birth. They also had up to 47% lower risk of lower birth weight infants, and then also up to 47% lower risk of fetal loss. So really highlighting that, the best quality diets were protective against these poor pregnancy outcomes. And so just to summarize, this paper, we, determined that, diet quality during pregnancy was important for birth size for infants. And we had also done another sub-analysis within this research where we looked at whether if women also consumed really diverse diets, whether that was also important for the size of the infant. And we found that that was the case. And so based off of these findings, we think that the next steps are really should really focus on trying to find solutions that increase diet quality for women during pregnancy. So this is just paraphrasing, and I'll move on to the next area that I want to just highlight for you. Another area of interest is really we are interested in also understanding the role of, pregnancy diets or just diets in general as it relates to non-communicable diseases. And this is because we know that on the African continent, for example, non-communicable diseases such as cancers, diabetes, and hypertension have been really increasing exponentially. For example, data suggests that 1 in 22 adults in sub-Saharan Africa may be living with diabetes, and a lot of these cases are not diagnosed. So with this in mind, we determined to do a meta-analysis, which is a summary of all the studies that have looked at diet and NCDs on the African continent. And one of the motivating factors for why we wanted to look at diet is that there's this really huge increase in access to processed foods, fast foods, and so forth on the African continent. So for the next 2 or 3 slides, I'll just focus on the studies that looked at diet and diet-related cancers, just a subset of the work that we did. So we searched, different databases for studies published from 2000 to 2024. We looked for longitudinal, prospective, and cohort studies as well as case control studies. And we sought to understand relationship between food groups in dietary patterns with diet-related cancers. So we looked in 24 years across the African continent, and we only found 20 studies. And as you can see, the studies themselves are really just spread really thinly across the continent, highlighting a really huge gap in data availability. Now, when we looked at the different foods and food groups and their association with cancers of the GIT, this table kind of summarizes the evidence that we found. On average, we found, there were some associations where fruits and vegetables were protective against colorectal cancer, gastric cancer, for example. We also found higher risk of colorectal cancer with alcohol, fast foods, and processed foods. However, we noted that most of the studies were case control, and that's really poor quality studies. And there was really limited, sparse evidence across the different outcomes. Now, with that in mind, some of the takeaway messages for us within our research group is really just the need for more studies that are prospective on the African continent that look at the role of diet and different non-communicable diseases. At the same time, we're also involved in a sub-study in Tanzania, which is trying to understand if fruit and vegetable intake were to be increased and people consume those, would that be protective for women of reproductive age? And so we're trying to think about, the role of fruit and vegetable intake and risk of diabetes and hypertension. So this just illustrates some of the studies that I've been involved in, and I'm happy to answer questions that pertain to my work in global health or any other question that might be of interest. I'll stop here by just acknowledging that all the work that I am presenting is a product of collaborations across multiple countries and research institutions. Thank you.
Thank you so much, Dr. Madzorera. Sorry, I want to make sure I was muted. Thank you so much. That was such an informative presentation. I think going in detail about the determinants of health and especially for maternal and child nutrition. So thank you for that. With that, we're transitioning to our last speaker. Dr. Sheri Weiser, an internist and professor of medicine in the Division of HIV, Infectious Diseases, and Global Medicine at UCSF. She co-founded and co-directs the UC Center of Climate Change, Health, and Equity, where she's working to expand climate and health research, education, policy, and clinical initiatives. Her research over the past 25 years focuses on the impact of food insecurity, extreme weather events, and other social structural factors on treatment outcomes for HIV and chronic diseases. She also evaluates sustainable food insecurity and livelihood interventions as a way to improve health, and her work has been used to change policies, programs, and practice nationally and globally. She has published intervention as a way to improve health, and her work has been used to change policies, programs, and practice nationally and globally. Sorry, I skipped that. She's published over 300 peer-reviewed manuscripts and has been principal investigator on over 30 grants in these topics. She's mentored over 80 students, fellows, and junior faculty, and was awarded the UCSF Distinction of Mentoring Award and the UCSF and UC-wide Sustainability Awards. She serves on the UC Global Climate Leadership Council and recently on the U.S. Climate Security Roundtable to advise the Department of Defense and Congress about how climate change affects national security. She's an internist and has been working with disproportionately impacted populations with HIV since 2001. Dr. Weiser, please take it away.
Thank you so very much. So a lot of my research over the years has really focused on how food insecurity negatively impacts health as a sort of first step. And then the second step is looking at interventions. I'm not really going to focus on the first part, but I will just start with a conceptual framework that will be useful framing, which is many years ago, we developed a conceptual framework to understand the bidirectional links between food insecurity and poor health. And I'll review that quickly. So you can see that food insecurity directly contributes to poor nutritional status, poor mental health, and poor adherence to treatment and care recommendations, leading to increased incidence of chronic disease and HIV and worse outcomes among those affected. This then drives utilization of expensive health services such as hospitalizations and emergency department visits, which then increases health costs and contributes to increased disability. This then further entrenches individuals in higher levels of poverty and unemployment, which then perpetuates a vicious cycle between food insecurity and poor health. Now, turning this framework around, and where I'll be focusing today, food security interventions can really reverse this vicious cycle by leading to improved nutrition, improved mental health, improved health behaviors, ultimately leading to improved health for HIV and chronic diseases, and in turn leading to reductions in acute care use and cost savings. And there are many different strategies we can use to improve food security, from food vouchers and food support to more upstream interventions like cash transfers for food and livelihood and vocational training programs. And importantly, understanding the mechanisms of which intervention of how food insecurity is worsening health can really influence the type of intervention we choose. And let me just give you some examples of this. If, for example, the nutritional pathways predominate, then provision of healthful food baskets along with dietary counseling may be an effective approach. But even then, the intervention type will differ depending on whether the negative health impacts are mediated by obesity or undernutrition. And if either behavioral or mental health pathways are more critical, then income transfers for food may better target ongoing anxiety about the food supply or the need to procure food in socially unacceptable ways. And likewise, skills and vocational training programs can really help address those upstream determinants of food insecurity. And in the interest of time, I won't go into the immunologic pathways and potential interventions. So let me give a few examples of interventions we've worked at, starting with our work in Food as Medicine. And this is really a suite of interventions aimed to alleviate the negative health impacts of food insecurity and poor diets, particularly for individuals with chronic or diet-sensitive conditions. So these include things like medically supportive food and nutrition programs, produce prescription programs, and all of these usually rely on provider referral and linkage, and they often integrate an aspect of nutrition, education, and counseling into their programs. And I'll give you 2 examples of food as medicine interventions that we worked on. This is along with Dr. Kartika Pilar. And this has been a long-standing collaboration with a free meal distribution program, Project Open Hand, where we've really co-developed these interventions over the years. And this one was a randomized control trial to look at the impact of medically tailored meals on HIV health in San Francisco and Alameda counties. The intervention was called Changing Health Through Food Support, or CHEFS, and provided 3 medically tailored meals per day, plus nutrition education to individuals living with HIV. And going back to our model, we did find that indeed the intervention improved health along nutritional, mental health, and behavioral pathways. So, for instance, we found a 77% lower odds of food insecurity, a 68% lower odds of screening positive for depression, and an 82% lower odds of ART adherence in the intervention compared to the control group after 6 months. We also found 95% lower odds of having sex without a condom, and importantly, 89% lower odds of a hospital stay in the previous 3 months. We did not find statistically improvements in viral suppression. And the finding on reductions in hospital stays is particularly policy relevant, since we know, for instance, that the cost of an inpatient stay at the time of our study was around $13,000 a day in California. And of course, providing food is a much less costly preventive intervention. And in our qualitative interviews, participants described changes in their health also along nutritional, mental health, and behavioral pathways, reinforcing that quantitative data I just went over. And so in the nutritional pathway, participants talked about improved diet and a more healthful diet as a key theme. And I'll just read that first quote here. I felt so much better because I was slowly putting the weight on and bulking up, so I made sure I was eating healthier. Before I would eat just like maybe 1 meal a day. In the mental health pathway, themes included reductions in stress, anxiety, and symptoms of depression, and the importance of the intervention as a form of social support. And finally, in the behavioral pathway, participants really talked about the ways in which the intervention supported both medication adherence and getting to appointments. We then tested a similar version of this intervention focused on diabetes in a subsequently funded R01 study, which is now ended, and we're just in the final stages of data analysis. So where we're at now, and a sneak preview of our results are that we did find, statistically significant improvements also in mental health and food security and nutritional variables and some of the behavioral variables, as well as a trend towards improvement in glycemic control. So stay tuned for those results. And then in the last few minutes, I'll just briefly turn to livelihood interventions, which are really a promising way to improve food security and health outcomes. And for approximately 15 years, I've been working with colleagues Craig Cohen and Elizabeth Bakusi on an intervention study in Western Kenya we call Shamba Maisha, which means farming for life in Kiswahili. And this is an intervention that is really responsive to climate-related drought, water insecurity, and food insecurity as a way to improve health outcomes. So the intervention includes a loan to purchase a human-powered water pump that then enables our farmers to irrigate their lands during the progressively longer dry seasons. And it also includes training in sustainable farming practices and financial management. And as an environmental benefit, our farmers practice regenerative agriculture, so helping to replete the soil of essentially depleted nutrients. And so we had hypothesized that this multi-sectoral climate adaptive intervention would first lead to improved food security and income, which would then contribute to improved nutritional status, adherence to treatment and care recommendations, and enhanced women's empowerment and mental health, leading to decreased morbidity and mortality. And what did we find? Well, in our efficacy trial with over 700 participants, we found improvements along many of these pathways. So improvements in food security, mental health, women's empowerment, social support, reductions in HIV stigma and discrimination, improved physical health status among men, and even reductions in violence, as you can see in the quote on the right. And the trial also impacted other members of the household. So for example, in a paired trial where we followed 241 adolescent girls living in Shamba Maisha households at Endline, the adolescent girls had improved food security and body mass index, fewer symptoms of depression and anxiety, and reduced sexual intimate partner violence. And this really does highlight the benefits of household level interventions, where you see the health benefits that can trickle down to other household members. And now there's 2 ongoing trials, one that I co-lead with Dr. Jennifer Veloza and Marciana Onono, which is the next phase of the adolescent Shamba Maisha trial, and another one led by Dr. Craig Cohen and Pam Murnane. Valgoda Otieno focused on improving maternal child health outcomes. And I just point out that we also learned that solutions need to be flexible due to unanticipated climate challenges. For example, our water irrigation solution worked well for drought, but when the weather shifted over time to also include excessive rains, well, crops were flooded and eaten by hippos. So we had to devise different solutions in future trials, such as potential crop loss insurance for flood damage and digging trenches to keep the hippos away. And in the final minute, I'll just talk about another environmentally sustainable model that is good for health, good for the environment, that has been engaged as a strategy to address food security and diet quality in urban areas, which is community gardening. And we conducted a small pilot study among Hispanic individuals living with HIV or diabetes in San Jose to understand the health impacts of this urban gardening project. And participants also noted improvements along nutritional, mental health, and behavioral pathways. So just for one quote on mental health, participant says, having the garden has gotten me through some pretty tough times. It's like therapy. I got out there and I just garden and plant. I found it very therapeutic. So in summary, we've seen that food insecurity and poor health interact in a vicious cycle. Leveraging synergies between food insecurity and related challenges can really address multiple health problems simultaneously. And I think all of this work across all these presentations really show that addressing fundamental human rights, such as access to food, should be an integral component of health programs worldwide. And I will end there. Thank you very much.
Thank you so much, Dr. Weiser. And thank you all for such insightful presentations on such global health topics. So if all the speakers can turn the camera back on, we'll now move into our moderated discussion. And so with that, if folks want to either in the chat or in the Q&A function, please start sending in questions that you have about the presentations, questions about nutrition and food security that you have. But I do want to start off to give space for you all to answer this question, and then I'll share some from the audience. To ground us, how do you define equitable food access? And what's often missing from that definition in policy or practice? And I will give space to whoever wants to answer first. And I'll put it in the chat too, just so that way.
I think, the Gates Foundation has used the terms affordable, accessible, and appealing, which I think is somewhat inclusive. There's always nuances, depending, I think, if people are looking down from a policy level versus, actually being on the ground in a situation, hungry and trying to get food.
I also think, just to add on to Dr. Waterman's definition, that something that also is really important is thinking about whether people have, the access to healthy diets that are in line with their we can think about, cultural practices, uh, anything that is specific about them that they would like, religion and things like that. And equity in terms of quality, not just in terms of having the nutrients, but the nutrients that you desire based on how you would like to define who you are as a human being.
Great. And I will just say, I think I'm just sort of reiterating a little bit what's said, but just maybe framing it in some of the formal definitions. Because when you're thinking about the sort of food and agricultural organization definitions, the components that we need to think about are food availability, food access, food utilization, or the ability to consume a nutritious diet, and stability. And, we have operationalized this in our research. A lot of this sort of food security definitions out there that in research often really look mostly at food access. Do they have enough? Or they may add on, do they have enough and do they have a good enough diet quality? But the other dimensions that are often missed are two really key components, which is people's anxiety and uncertainty about this food supply, and also feeling that they need to procure food in socially unacceptable ways, which may include, for instance, for women, exchanging sex for food and many other things that people have to resort to keep themselves and their families alive. So I think when we're thinking about equitable access, we really do need to think about all of these dimensions.
Thank you all. One question that we have is from Anthony, who is one of our student ambassadors from UC Irvine. He said, "Thank you all for the wonderful work you do around the world. I noticed that much of your research has a global scope, often engaging with different populations, communities, and demographic contexts. So how did you come to study the demographics of regions that are central to your work, and what drew you to those communities in particular?" I'll give space to Dr. Weiser to go first.
Sure. So I didn't present all the places that I work. I think I was drawn to communities both because a need was identified in those communities. Like, for instance, my work with Project Open Hand, that emerged honestly from my own work, working at a safety net hospital at San Francisco General and seeing all of the ways that food insecurity undermined health for my patients. It also emerged because Project Open Hand uh, approached me and my colleague Kartika and asked us to co-develop an intervention with them so we can provide data to what they knew was working. So it definitely emerged by intervention partnerships. And then my choice to work in some of the other settings I work, like Kenya, and now I work in the Philippines and Rwanda, also emerged from partnerships and communities and collaborators like Craig Cohen, who reached out to me many years ago to increase collaborations because they saw synergy in what was happening on the ground with my work.
Yeah, I can comment on that and certainly echo what Sheri said and give the specific example of, applying for a Fogarty grant, having lived in Kenya, having thought that as an interest, and finding Craig Cohen's guide at UCSF to applying for Fogarty K01 grants, learning about the Shamba Maisha project, and actually being able to go there and learn more about it while planting moringa and working on my own project. So I think some of it comes from, your own experiences and people that you meet and professors that you have. But then there's so much cross collaboration and introduction to other folks. And sometimes other opportunities just come up, right? So you want to be on these listservs. And so especially with the internal grants, like with the UCGHI, these grants that are $5,000 to $50,000, it's good to just stay in those networks to know about those opportunities. But I would say, yeah, I'm still working with folks that I'd met or networked with from 15, 20 years ago, and those still continue to build. And I still use Shamba Maisha as an excellent example of an agricultural intervention with health outcomes, and looking at these cross-sectional projects that brought together folks from so many different disciplines. And so, Sheri, it's also really good to see you and always appreciate your presentations as well as Isabel. So.
Thanks, everyone. Maybe just to add, for me personally, I think I just echo colleagues' thoughts on networking and finding out what people are doing and reaching out to folks. I think for me, I'm from Zimbabwe, and so a lot of my work is really focused on sub-Saharan Africa because I grew up there and I did my undergrad and started working there and came here when I was a master's student several years ago to go to Tufts. And, over the years, my interests honestly have changed over time. I think one thing that's really been important in kind of influencing where I'm working now is just being open to new ideas, new collaborations, sometimes also just reaching out to people. And a lot of the work that I do now is tied to the work that my mentor in my PhD program was also doing, and introductions that he's made, and then people that I've also met along the way. So I think a lot of what could drive you could be personal relationships, personal experiences, but also I would encourage folks to reach out to different faculty, different mentors, different practitioners that are doing the work that you're interested in. And that could be one way to get into the space that you would like to get into. Yeah.
Thank you for that. And I think that's a good reminder that the work's like ever changing. Like it's not the same as what was happening 20 years ago. Like obviously new topics, new conversations, new research is happening. So Michelle in the chat said, thank you so much for these great presentations. I'm curious how you see the role of foodborne diseases in each of your work. I'll give space to whoever feels comfortable speaking to.
I mean, I could speak to this because that is leaning into some of the work we're doing now on extreme weather and health. And one of the key intersections that we're looking at is how extreme weather, like drought and flooding, intersects with things like food insecurity to worsen outcomes, and particularly related to infectious diseases. And it's very clear that both the drought and flooding are for different mechanisms leading to both food insecurity as well as contamination of water supplies and a lot of water insecurity. And this sort of intersection between food and water insecurity is really at that place where we're seeing emergence of more kind of foodborne and waterborne infections. And so I think that is an increasingly relevant topic as we think forward of how to address food insecurity in the context of worsening climate change, and something that we really need to be very sensitive about. And I have a current project right now in the Philippines where we're actually looking at extreme weather and HIV, and that has come up a lot because of typhoons and the kind of waterborne and foodborne illnesses that are arising in that context. And I will turn to others.
Yeah, I've done a little bit of work just kind of on aflatoxins and looking at like post-harvest storage. And obviously these issues are exacerbated in the time of drought or climate crisis or political crisis, so sometimes in these already really tough conditions, then you have even more pressure. But really looking at safer storage mechanisms. And there's a lot of organizations, at least in East Africa, that I've worked with regarding that, and looking at different ways to coat seeds. Even with moringa, you can put a coating on the outside of avocados, better storage, and then also for grains, because aflatoxins just still remain such an issue. My PhD was on looking at plants that are anti-helminthic, because there was such a large proportion of helminth infections, with still a predominance of like a WHO or international organization coming in for those interventions, rather than being it somewhat locally based and found, or at least a diet that would help promote a bit of health there, because it is tricky once you have some type of infection. Even if you're getting all the nutrition, they're usually consuming those nutrients then. And so this is why you have to have this multifaceted, I think, approach to food security.
Right. And I think also, just to add on to that, I often think about foodborne diseases within the context of food safety. If you're thinking about reducing food loss and waste, so we often think about food loss and waste, like let's say food waste at the household level here in the United States, where people are buying food and they're losing it at the household level. But in many low and middle income countries, there's a lot of food loss, which is the food is being lost in the field, on the way through the food system value chain, even before it reaches the consumer. So one of the critical challenges, particularly if there's no access to refrigeration, electricity, or food preservation approaches that are appropriate. So a lot of the food is either contaminated or lost. So if we're thinking about how to increase food availability or reducing the average cost of food in the African continent, for example, where I do a lot of work, there's often a lot of thought around how do we think about safe storage and also restriction of contamination of food, which is not only impactful in terms of health and health outcomes, but also reduces the food that's available for folks to consume. So really important to think about food safety and foodborne diseases within food storage, food safety, and how it impacts health and nutrition.
Absolutely. Thank you all. Another question we have in the chat is from Leanne, one of our student ambassadors as well. Thank you so much for presenting your extensive works in global health, since many of the projects highlighted today have been either been conducted within the US or other countries, I was wondering how translatable food security and other health interventions have been between countries. Are interventions or exploratory studies relatively simple to implement regardless of the country you're in? Or do you have to implement insignificant changes and conduct further research in each target population you work with? And I'm going to send that in the chat so you can see it yourself again. This is a long question. Um, whoever would like to go first.
I'll let someone else go first and then I'll chime in.
Sure. Thanks. I think that, there's a lot, like what I've learned in my, I think now I have many years of experience in global health. And when I first started, as I indicated, I started working in sub-Saharan Africa. And when kind of switched and came here, I thought, well, I'm not going to find a lot of places where my experience and expertise is going to be, applicable. But I've actually been really surprised because a lot of the fundamental things that we worry about in different environments, yeah, maybe the priorities are different, but the fundamental issues are actually the same. For example, food insecurity is everywhere in the world. Food safety issues, concerns around that are everywhere in the world. So there are certain constructs that can certainly move from different regions of the world. But having said that, I do think that if you are the one conducting research in a new environment, I would not recommend just taking project as it is in one region and just kind of transplanting it. The need to tailor projects and make sure that they're suitable for the specific region that you're working in is really critical. But having said that, I do see many parallels in terms of things that have started globally and are now, for example, being done in the United States. A good example I can think of, like within outer processed foods, and the thinking around them has been in the global domain for a number of years. And it's only now that we're seeing a lot of uptake within the United States, where even now, in California, schools are trying to have outlawed outer processed foods. So maybe California has taken it a step further, but the discussion, the global discourse is actually one that has influenced local conditions. So I think that there are parallels and there are lessons to be learned from different environments. Yeah.
Great. And I could chime in to say that that has been a huge, I would say, part of my career focus has been thinking about translation of potential interventions and ideas across these contexts, because I've always worked sort of both domestically and primarily in sub-Saharan Africa, but also elsewhere. So when I first started even studying how food insecurity affects risky sex, women's disempowerment, and ART non-adherence, I didn't know how that would play out here, but we then did studies here and we found very similar effects, but slightly different mechanisms in populations. Many much more in the US, the food insecurity was much more linked with maybe severe mental illness and with substance use and with a lot of, racism and exclusionary practices, et cetera. So it's just the populations and the issues that were driving it were somewhat different. And then when we started looking at interventions, I started working and collaborating with the World Food Program on food baskets. And that was sort of similar, but still quite different than the kind of medically tailored meals that are much more comprehensive meals provided, in at least the Bay Area where we're working by the free meal food programs. So then when we started working on Shamba Maisha many years ago, we were like, okay, this was a model that we really wanted to replicate. It had environmental benefits. This livelihood focus was so empowering compared to sort of just giving people handouts. And we've spent a lot of time thinking about how and whether we could replicate that domestically. And the bottom line is it's not really very translatable. That did lead me, though, eventually to look at these urban gardening interventions, which is just a subcomponent. It's not a livelihood, but it is growing your own vegetables in a sustainable way. So in my experience, there's a lot of lessons learned, but then I very much concur with what Isabel said, that these really do have to be tailored. There's very different contexts, both circumstantial, cultural, et cetera, that require, and environmental, that require different tailoring.
And I can just add on to that and kind of, I think, like decision certainly there are some similarities in interventions across different locations. But I would say like the biggest theme is kind of, have those populations been involved in research before, and how much trust has already been built, or have they been involved in research that did not go well? For example, like we were working in communities that had negative experiences in being a part of an intervention. And so they were not willing to participate. And so versus, communities that had a long-standing relationship with the community-based organization that was going to administer the intervention. So I think that goes for across whether you're in the US or whether you're in a rural village in sub-Saharan Africa. I would say looking at the state job that we do right now with nutrition incentives, it's very different how those incentives get distributed. Whether you're at a farmer's market, you use your EBT and you get an extra $15 in coupons to go give with the farmer, because that works for the shopper and the farmer. At a downtown Los Angeles location, most of the shoppers are unhoused. And so they pre-package the fruits and vegetables, and they select fruits and vegetables that don't require cooking. So you're not getting a squash if you live on the street corner. You're getting oranges and carrots and things that you can eat right away. So there's very specific tailoring by those nonprofits that make sure that those systems of access are super relevant at that street location that they're distributing food. So it really is nuanced. And again, I think the reliance is on that trust that's been built. And if it's a new community, then that really does take time, I think, to implement.
Thank you all so much. We do have one more question, but it is from one of our students, and so I might save it for the student networking session that we have after this. So I just wanted to give a big thank you to all of our speakers for taking the time to talk through with us, present with us, and really teach us your expertise around nutrition and food security. This recording will be sent via email and will also be available on the UCGHI YouTube channel and our website, along with us sending out a post-webinar survey for you all to fill out your experience. But I want to just reiterate, thank you all presenters for the time, and I really appreciate everything that you shared with us today. So thank you. Awesome.
Thank you so much for having us. And do we stay on this link, or we have to get on the other link?
We'll be going on the other link.
Other link. Okay.
Thank you.